Well, good morning. I think the Young Investigators Award probably should be taken off as part of distant history. These are the disclosures. You've already seen a bunch of disclosures. The CME for this comes from the Medical Education Resources, not Purdue. And these are my disclosures, as well as the people that I developed the material with. So what we're going to learn over the next says 52 minutes and 14 seconds, but I'll keep it to 40 so we have time for questions, is we're going to talk about the epidemiology of MASLD, or metabolic-associated steatotic liver disease, the disease formerly known as NAFLD. We didn't go to a symbol like Prince, which would have been better. We're going to talk about using non-invasive tests, or NITs. I hope by the end of this, you'll realize that you do not need to do a liver biopsy to stage disease anymore. We still do liver biopsies in patients who we don't know why they have abnormal liver tests, but if you're doing liver biopsies to figure out fibrosis stage, hopefully by the end of the lecture, you'll be convinced you don't need to. We're going to talk about lifestyle modification, and I think it is important that we go through some of the details and the data supporting weight loss interventions. And then we're going to talk about treatments, medical treatments. This is the accreditation. You can get one CME credit. You got to do the pretest. I already did it. I'm pretty certain I got it right. But by the post-test, hopefully you'll get 100. So that's how you claim your credits. This activity was supported by an educational grant from Madrigal, but they had no control over the content. And anyone who knows me, no one has any control over me. So, we talk about epidemics and pandemics, and I think everybody accepts that we are in the middle of a growing obesity epidemic. The BMI in America is increasing year on year. The prevalence of type 2 diabetes is increasing year on year. And it is estimated that probably if we ultrasounded every single person in the United States, we would find fatty liver on ultrasound in about 38%. And any of you in GI practice know, because you're getting referrals from primary care doctors right and left for fatty liver on ultrasound. If you're not, then you can see some of mine. And it is not it's not a U.S. problem alone. It is estimated that about 30% of the population across the world has steatotic liver disease, and that's because of differing risks across the country. In some places, it's diabetes. In other places, even undernutrition can lead to MASLD. But NASH, the progressive form, is probably about 5%. And 5% seems pretty small, but when you apply it to the world population or the U.S. population, you end up with a pretty big number. And so the other issue is that the age at which people are becoming overweight and obese is getting younger, and childhood obesity and childhood MASLD is going to be an increasing problem. And they think that about that fatty liver may be present in as many as 10% of children. And as I said, type 2 diabetes is increasing across the world. And if you have type 2 diabetes, the likelihood that you have MASLD is about 60%. So the first pearl of my lecture is pay attention to people with type 2 diabetes. They are your highest risk group for fatty liver, and it is the most intervenable risk factor. And as I said, the prevalence of MASLD with type 2 diabetes is also increasing. So type 2 diabetes not only increases the likelihood of having steatotic liver disease, it increases the likelihood of having the progressive form, or steatohepatitis, or MASH. It also increases the risk of cancer in those patients who have cirrhosis. And the reverse is also true, that fatty liver promotes insulin resistance. And so you get into a vicious cycle where MASLD makes people more insulin resistant. More insulin resistance leads to more fat deposition in the liver, and the cycle continues. So be aware of patients with diabetes, because if we take just the group of patients with fatty liver, and you look at their all-cause mortality, which is at the bottom, it is double the general population. And most of that is due to cardiovascular risk. So for many of our patients, MASLD is not a GI problem. It's a problem for cardiologists, endocrinologists, and primary care. They will still come to see you in clinic, but you have to tell them that their problem is CV risk and that they need to go back to their primary care. And what I tell them is that their liver is a bellwether for their heart and their coronaries and their carotids, and they need to manage it. But you can see that liver-related death is still increased compared to the general population. But if we look at patients who have cirrhosis from MASH, now their rate of liver-related death is thrice the general population all-cause mortality. And of course, cardiovascular rates are also higher. And you can see that group of patients has 10x the mortality of the general population. So if we want to improve outcomes, we have to identify those that are highest risk of having progressive liver disease and stop them before they develop cirrhosis. So how do we figure that out? Well, one thing is be attentive to their metabolic risk factors. So I told you about diabetes. Diabetes is the worst, but the more you have, the worse you are. Now, of course, most people with type 2 diabetes, at the very minimum, are going to have 2 because they're almost all obese. So they're going to be down there. But if you have that and hyperlipidemia, one more thing, and if you have hypertension, you're down there where your likelihood of being alive in 20 years is 40%. So how do we, as gastroenterologists and hepatologists, figure out who's in our bucket and who's in the bucket of the endocrinologists and cardiologists who want to send us every patient with fatty liver on imaging and mildly abnormal liver tests? And the answer is it's about fibrosis stage. So fibrosis stage predicts all-cause mortality, but it also predicts liver-related mortality. So you can see if you have stage 0 or stage 1 fibrosis, your liver-related mortality is not increased compared to the general population. But when you get to fibrosis stage 2, it starts to rise. And when you get to 3 and 4, it goes up markedly. And strangely enough, all-cause mortality also increases because the more you have liver disease, the more you have cardiometabolic risk. So now you're compounding their risk of all those adverse outcomes. So what I would say is I draw the box in between stage 1 and stage 2 where this becomes my problem in addition to the cardiologists and endocrinologists. So the point is we need to focus on fibrosis. And the second question is, well, if we make fibrosis better, will we make outcomes better? And there is data to support that. And actually, it comes from a trial of a drug that never made it to market. So the Stellar-4 trial of simtuzumab, you don't need to know about the drug because it never made it to market. They looked at fibrosis stage on their biopsies, and then they had a long-term follow-up because it took a long time to finish. And by the time they got to the endpoints, they had this data. And they looked at patients who had fibrosis regression compared to those that didn't, and how was the liver-related morbidity, because they were studying patients with cirrhosis. And what you can see is if you had fibrosis progression or stability, you did much worse than if you had fibrosis regression. That's close to a 90% reduction in risk. So if we can make people better in terms of their fibrosis stage, we will improve outcomes. So how do we do fibrosis staging? And I'm going to tell you that you don't need a liver biopsy. So these are the stages, right? We remember this from medical school. I was terrible at pathology. All I would do is blue is bad. And so if I saw more blue, I tended to try to pick the worst answer. I did get a passing score, but not an A. And so fibrosis is bad, and the stages go the same as stages for Hep C or whatever. Stage 0 is just steatosis. And then when you get inflammation, that becomes MASH, and you get ballooning, and then you get fibrosis. Remember, the fibrosis here is that chicken wire fibrosis along the sinusoids, and eventually you form nodules, that is cirrhosis. So you can tell on a liver biopsy, but I'm going to tell you, you don't need it. And the first thing, and this is one of your questions on your pretest and thus on your post-test, the first thing you should be doing is FIB4. And if you have EPIC, all you have to do in EPIC is write .fib, and it will calculate it for you. Look at that. So, and the number you have to remember is 1.3. Now, in my little .fib, you can take the little calculator and you can modify it. And I have BBJ fib, and BBJ fib puts in parentheses the 1.3 and the 2.67, so that one in the beginning, so I remembered, and now, of course, I remember. But it also tells your referring doctors to remember, and they can remember 1.3. Now, you can't calculate the FIB4 in your brain unless you're the Rain Man. I can't do square roots in my brain, but it is a pretty simple. Everyone has an AST and ALT and a platelet count and an age, and it should do it. My push at New York Presbyterian is to have the FIB4 calculated at the bottom of the lab slip, just like we get the EGFR, and hopefully it'll work. So there is a new test on the block. This is available commercially from Quest. And if you haven't incorporated it into your clinical practice, I highly recommend it. I like it better than the NASH FibroShort, not because it's better than the NASH FibroShort, but because you don't have to fill out the lab slip with the BMI and the diabetes yes, no, which LabCorp seems to lose all the time when you do it electronically. If you do a NASH FibroShort, print out the slip, give it to your patients, and tell them to tell LabCorp to shove it in the bag. And that will eliminate those ones that come that says you can't calculate the NASH FibroShort. The reason they can't calculate it is because they will not calculate the BMI or whether they have diabetes. This is independent, and it includes totally different biomarkers. So for your patient, for example, has a high AST and ALT, that may give you a falsely elevated FIB4, as it will in older people. This just looks at collagen biomarkers, and you can see that it has a pretty linear relationship to fibrosis stage. And the easy number here is 8. I don't use 7.7. I like to remember easy round numbers. 8, because 8 also is my FibroScan number that I remember. So the second number to remember after 1.3 is 8. And you can see that it's quite linear. I don't own any stock in the test or in Quest, but you can only get it from Quest. Transient elastography also works very well, and you can combine transient elastography with AST. I don't ever calculate the FAST score, but it's out there. I just use transient elastography. Once again, the number is 8. So if they're 8 or below, not your problem. Back to endocrine, back to cardiology. Above 8, your problem. And then probably the gold standard test for non-invasive tests is MRE. MRE and MRI-PDFF, which is proton-derived fat fraction, will tell you the fat percentage and the fibrosis stage. Only problem is it's expensive. But if you have a place that will do your MRI with an MRE, particularly for your obese patients, it is great. You can see here, just to screw with you, red is bad and blue is good. So whatever. But that's why probably rules like blue is bad don't really work well. And what you can see is that the MRE changes over about 6 months. FibroScan takes about 12 months to have a substantial change. So I hope I've convinced you that you can use your NITs to stage your patients. And if you may need 2 tests, may need 1, you start with the FIB4. If they're fasting and you have FibroScan, you can go to FibroScan. If not, you can send the ELF. Your primary care doctors can send an ELF. And if all else fails, discrepant tests, MRE. So now what about predicting outcomes? Is the change in FIB4 over time meaningful? And the answer is yes. So what you can see is that if you have a high FIB4, that's the number at the top, you do the worse. If you have a low FIB4, you do better. And if your FIB4 increases, which are the solid lines, you do worse. And if your FIB4 gets better, you do better. So the other thing you can tell your primary care providers is they can follow FIB4 over time, and a stable or improving FIB4 is better than one that is getting worse. And the same thing is true for elastography. A high CAP score or a high liver stiffness score predicts bad outcomes. And if it gets better, they do better. So we should be using these tests serially to measure the outcomes. And of course, ELF, same story. I don't have change in ELF over time, but higher ELF, worse outcomes over time. So you not only can tell that it predicts their fibrosis stage, you can tell them that it predicts their morbidity and mortality, and that improving it will improve their morbidity and mortality. And those numbers should be both encouraging, meaning I can get better, and at the same time sobering. If I don't do anything, I'm going to perish. And, I tell people, look around, retirement communities, you don't see people with a BMI of 50. Something happens to them. They lose weight or they don't get to retire. And MRE also can measure response. So this was from the resmetirom registration trial. They had an MRE at the beginning, an MRE at the end, a liver biopsy at the beginning, a liver biopsy at the end. And what you can see is that the MRI fat fraction decreasing shows whose fibrosis will get better. So you don't need to do a liver biopsy. We can predict outcomes and measure response using NITs. So it can not only bucket our patients at the beginning, the serial changes will tell you who's going to get better and who's not. And that is how we're going to decide on who needs additional treatments and eventually when to stop treatments when the NITs respond. And of course, MR elastography also predicts outcomes beyond cirrhosis. So it not only can predict cirrhosis, it can predict the risk of decompensation. So we have cirrhosis. Remember, MRE has numbers that are much lower than FibroScan. So 4 is about where cirrhosis starts. Why they couldn't just make it 8 and 10 in the same numbers, I don't know. But fortunately for MRE, it comes with a if your report doesn't have the handy-dandy numbers, tell your radiologist for $4,000 they should do a better job. Ours do. Well, they charge the $4,000, but they at least give me the exact amount with the fibrosis stage. And you can see that 4, you have cirrhosis. Above 6, you're at risk for decompensation. 7, that's when you start to develop ascites, and it is pretty linear all the way up, well beyond where FibroScan can, because once you have ascites, FibroScan's useless. So now you have all this stuff. How are you going to use it? And so the answer is we're going to come up with some complex guidelines that will hopefully guide you that you can't read on this slide. And so I'm going to tell you the key. You can get the slide. It's, of course, published. But it starts with the FIB4. And if the FIB4 is less than 1.3, you're done. Shove them off to the side. every primary care doctor I asked, I said, what should I do with my patients with fatty liver? I said, calculate a FIB-4. And if it's under 1.3, please don't refer them. Just manage them and use statins, even if their liver tests are abnormal. And you've done the God's work. If it's above 2.67, right over to GI. They have advanced fibrosis. And in between, do a second test. And that can either be done if you have a place that will do open access FibroScan. We do open access FibroScan. You don't have to have a GI consult to have a FibroScan. Just do the FibroScan. Or if they come to my office and they're not fasting, I send the ELF. Sometimes I do both. And if then you can then rebucket them, low risk, ELF less than 8, FibroScan less than 8, back to primary care. Above, then you should be thinking about therapy. And this is the ASLD recommendation because, of course, liver people have to make it even more complex, but it says the same thing. 1.3. Some say for type 2 diabetes or diabetes who have complications of diabetes, you should probably ratchet it down a little bit. I think if there's one group of people who should get a secondary ELF pretty much across the board, it's any type 2 diabetic who's not well controlled. And then use those same thing, your first test and your second test to know who needs GI hepatology care. Because the patient with fatty liver on ultrasound and normal liver tests and a FIB-4 of 1 and a platelet count of 250,000 just needs to be managed by primary care. So, and then if you want to make it even more complex, you can have other things. But then the other thing you have to know is that top end. Because these are the patients you really need to pay attention to. And that's the FIB-4 is above 2.67. And those patients, you cannot just say, oh, their FibroScan looks okay. Make sure they're okay. That has a 90% prediction that they have F3 or F4. And similarly, an ELF over 10. So for ELF, it's 8 and 10. For FibroScan, it's 8 and 12. But you should sort of know where these are. And those patients should be in cirrhotic healthcare maintenance. So we've staged our patient and they have NASH. And we need to do something, and they're in our practice sitting in front of us. What do we have to do? And the thing we have to do is we have to tell them about lifestyle modification. And we went into GI because we didn't want to do that. And now we have to. And so I'm going to try to make it simple for you because I can do this in a 15 to 20 minute appointment, and so can you. And the first thing I do is I tell them about the rule of 5 and 10. And that's how much weight loss they need. I used to calculate their ideal body weight, but if you ever calculate your ideal body weight, it's incredibly depressing. So I tell them 10% is our goal, 5% is in between, 5% will improve fat, 10% will resolve NASH. They weigh 267. It's pretty easy. That's 26.7, 27 pounds. Everyone says that's easy. I can do that. Of course they can't, but that's the first thing. The second thing is to talk to them about diet. And I talk to them about what they should eat, good fats and protein, and what they shouldn't eat, sugar and processed foods. And however they get there, they get there. And I think the Mediterranean diet's probably the easiest. And then physical activity, and I tell them it has to involve resistance training because muscle mass builds insulin sensitivity. That whole thing took me a minute. And then drink coffee. Because they tell you, I'm taking everything, you're taking everything I want away. No drinking, no sugar. I said, hey, well, you can drink coffee as much as you want, as long as you don't put 3 pumps of vanilla in there. No peppermint lattes. So then they'll say, well, what diet? And the answer is they all work. The Mediterranean diet has been the most studied. And I think the easiest to follow, because actually there are people who do this as a lifestyle, even not just to lose weight, whereas most of the others are just things to lose weight. But the key is no processed foods, if ever possible. I tell them all about looking for high fructose corn syrup, and anything that has that high on the ingredients list is not supposed to be part of their life. It's not a normal substance. It is delicious, of course. So here's the data. The Mediterranean diet, there are several studies showing that it improves insulin resistance, that it improves fatty liver. That's pretty simple. Now, what about intermittent fasting? All patients come and they say they want to do intermittent fasting. No one does intermittent fasting. Intermittent fasting is when you don't eat at all on a day. And there are two ways: alternate day eating and eating for 5 days and not eating for 2 days. I don't know how anyone does that. I can't make it from, sun up to sundown without having a cup of coffee in the morning at least. Most people, what they're doing is called time-restricted eating, where they don't eat till lunch. And the key there is there has to be, you have to eat, if they don't eat till lunch, they can't continue to eat until midnight. So it can't just be shifted eating, which is what most people do. It has to be time-restricted eating, which is why I don't call it intermittent fasting. Because, Ramadan, after sunset, you could go crazy until like 2 a.m. And they don't lose weight usually during Ramadan because they eat the same number of calories. The only way this works, it's a math problem, right? It's calories in, calories out. The number of times I tell people that they're not a plant and they cannot make sugar from the sun is astounding. So intermittent fasting does work, but I think is impossible to do. Time-restricted eating is fine, but then they have to eat between 12 p.m. and 8 p.m. And at 8 p.m., they got to stop till the next day at 12, which is hard. They can have black coffee in the morning, but nothing in it, 0. So, well, you try that and it doesn't work, of course. And so then what's your next choice? It's either meds, an endoscopic intervention, or surgery. And all of them work, and none of them are approved for MASH. But they are part of your algorithm because at the end of the day, we need our patients to control their metabolic risks. And so the first data came from bariatric surgery, and bariatric surgery works, and it works simply. You lose weight and it gets better. You don't lose weight, doesn't get better. There is no mechanism beyond that. The bariatric surgeons talk about hormones and everything else, but the data is quite clear. The resolution of MASH is directly proportional to the amount of weight loss. And of course, the more you lose weight and the more durable it is, the better it is. Simple. And you can see that there is data showing that people who have bariatric surgery have both improvement in their liver outcomes and their cardiovascular outcomes. And actually, the impact on their liver outcomes is even better than their outcome from a cardiovascular risk reduction. And so if you have someone who has stage 3 fibrosis and is morbidly obese, BMI in the 50 range, I think bariatric surgery before they develop cirrhosis and have a contraindication may be your best first bet. Then the second is we do have to manage the cardiometabolic risk. We're going to talk about resmetirom and managing the liver risks, but they're two separate, related, and intertwined issues. We have to address both liver disease and liver fibrosis and the risks. And you have to deal with their type 2 diabetes. You have to make your primary care doctors feel comfortable giving statins to people with abnormal liver tests. Pearl number, whatever. Stop making a big deal about statins. If the liver tests are high and you give them, the liver tests will get better. If the liver tests are normal when you give them, they'll either stay normal or go up because that's the nature of NASH. It goes up and down. And if you keep starting and stopping statins, you'll be convinced you're doing something when all you're doing is watching the waves. And then you have to deal with their obesity. And some of them overlap. And to me, this is why GLP-1s probably have a key element in the obesity and type 2 management in addition to managing the liver disease. So manage diabetes with approved drugs. And to me, approved drugs that lead to weight loss will improve NASH more than ones that just control hemoglobin A1C. But controlling hemoglobin A1C will improve NASH. But you shouldn't manage diabetes. Then the second is we got to treat the liver. So you have to treat the underlying liver disease, the underlying problem, and you have to treat the liver disease. And the FDA approved endpoint for this is you have to resolve NASH without fibrosis getting worse, or you have to improve fibrosis without making NASH worse. And a lot of drugs have fallen on the fibrosis regression because it takes a lot to regress fibrosis in a year. And the only drug so far that's crossed that finish line is resmetirom or Rezdiffra. It is an oral thyroid hormone beta receptor agonist. Trust me, when I started this, I didn't even know thyroid hormone had two receptors, and I got those. I didn't know what thyroid hormone receptor beta did. But what thyroid hormone receptor beta does is it affects liver-related lipid cycling. Thyroid hormone receptor alpha does all the other things that Synthroid does. And so you don't have to worry about thyroid effects of resmetirom, just as thyroid hormone replacement doesn't really help the liver that much. And it was approved a year ago. And so by stimulating THR beta, you decrease lipids, and it has some effect on fibrosis through TGF beta. The science, interesting, but not that important. But the fact that it affects fibrosis directly is why I think this crossed the finish line faster than many of the other drugs that are seeking approval, where they reduce steatosis but not fibrosis. So this was the Maestro NASH trial published in the New England Journal, 1:1:1, 2 doses of resmetirom, 1 and a dose of placebo. It was biopsy entry, biopsy conclusion, but the good thing is they had NITs at both beginning and end that we can now use to guide our clinical practice. And you can see that most of the patients had stage 3, 2/3 had diabetes, most had dyslipidemia and hypertension. So because they had bad NASH, they had all the elements of the metabolic syndrome. You notice 70% had dyslipidemia, 48% on a statin. Don't listen to me. 14% on a GLP-1, either for diabetes or obesity. These are two drugs that work differently and can work together. And they hit their key endpoint. So double to triple the rate of over placebo of both improving fibrosis and of NASH resolution. And I think the other thing that impressed the FDA that led to problems with some of the other drugs was a salutary effect on lipids, which was not seen with obeticholic acid, for example. Now, what are the side effects of resmetirom? Mainly GI. Diarrhea and nausea. They happen early, first 4 weeks. They tend to be self-limited. So you can tell your patients, 1, if you're going to have it, you'll have it in the first month. So if they get to the first month, they don't have to sit there worrying. And 2, generally does not lead to discontinuation. Manage it like nausea and diarrhea. You're a gastroenterologist, you know how to do that. But is an important thing. As I said, you can use GLP-1s and resmetirom. Brown expert point, don't start them at the same time. You will never know what the GI side effects are. They seem to be very highly overlapping, and then the patient will be on no drugs. So start one, whichever one you think you need more, whichever one you can get approved, whatever you want to do, and then wait 3 to 6 months, then start the other. So here's the dosing. Simple rule, over 100 kilos, 100 milligrams. There are some drug-drug interactions. Look them up. In the interest of time, I'm not going to go through it. So the nice thing is the AASLD did come out with NIT cutoffs for resmetirom, so that you don't, if the insurance company says they need a biopsy, shoot this off with your cutoffs of 8. I use 8 for both ELF and FibroScan. or MRE at 3. And then don't use it in patients who have advanced cirrhosis. Now, if they're just in between F3 and F4, you should know that there is no safety concern with compensated cirrhosis. They just weren't in the trial. But decompensated cirrhosis, there is a significant safety concern. So the second thing is you've started resmetirom. Now what? 2 important points. If you're going to measure liver tests at 4 weeks, be prepared, they will go up. They always do. So either don't do it or warn the patient and then measure them again at 8 weeks. I just wait till 12 weeks. And every 3 months, they do recommend checking thyroid function. It wasn't any impact on TSH, though some changes in free T4, but just measure it because you're measuring liver tests anyway and then send them back. The other key is FibroScan takes at least a year to change. So resist the temptation or the patient pushing to do a FibroScan at month 3 or 6. It will not change and they will get depressed. But the ALT will go down and they will be happy. And so be happy about the ALT decreasing. And what I tell them is, we're not doing a FibroScan for a year. Please don't ask. I'm not doing it. Because even if they say I'll be okay if it's the same, they won't be okay if it's the same. Then you'll be doing them monthly. And it just doesn't reimburse well enough to be worth it. So MRE will change in about 6 months, but who can get an MRE every 6 months? So do it at a year. Everything else, 3 months. So then the question is, when to stop? And the answer to that is, I don't know. But here are some guidelines. If they're getting worse, I guess you could stop, or you have to think about, I need to do better with the hemoglobin A1C of 11, or the fact that they're not losing weight. Weight loss on resmetirom, 0. So that's why these are 2 corresponding. If they're getting better, keep going. How long? My feeling is until they hit F1 or F0 on your non-invasive tests. Then they don't have an indication. That would be my simple rule. Haven't got anyone there yet, so I don't know. I haven't stopped anyone. But that would be, to me, the simple thing. Now, of course, if we haven't controlled their weight and their diabetes, they're just going to march forward again. But that I guess I could deal with that. But work on those things at the same time, and then you'd be able to stop and then just maintain their weight and diabetes. So what else? So there are therapies on the horizon. So both semaglutide and tirzepatide are in trials for NASH. Most of them have not yet shown a fibrosis improvement, but certainly a steatohepatitis improvement. And probably the answer is because they don't have direct impact on the liver, it's just going to take longer, like bariatric surgery. But I can't imagine that if you lose weight and keep it off, of course it's going to work. These FGF21 inhibitor agonists, I think, are very exciting. They're in phase 3. The preliminary data looks kind of good. And the answer is, I don't think it's going to be a question of this or that, because each of these seem to have a response rate of about 30%. So probably the answer is we're going to need combination therapy, just as we do for hypertension and diabetes and I think IBD. I guess you'll learn that later, but you probably do need it for IBD, but because the drug companies don't work together, they haven't been studied. So until you get to 100%, we're going to need more agents. And the answer is we're going to need to focus on antifibrotics for those with advanced fibrosis, and we're going to have to focus on anti-metabolic effects for those with early fibrosis, and it's going to be some type of combination. So what have I tried to tell you I did it in 40 minutes, exactly as predicted. You think I've done this before? Is that MASH is growing. If you think you're going to avoid it in GI practice, I want what you're smoking. You can use NITs, not just in GI, but if you can instruct your primary care providers, it will make your life so much better. I don't know how to instruct my primary care providers. That's probably a lecture for another day. I haven't done it. I still see patients with fatty liver on ultrasound and normal liver tests every freaking week. This is going to be a team approach. If we just deal with the liver, they're going to die of cardiovascular disease. If the endocrinologists just deal with the type 2 diabetes and obesity, they're going to die of liver disease. And we're going to really need to have a team approach. That's why we at Cornell started a multidisciplinary clinic. We call it iChange, where we have endocrinologists, dietitians, gastroenterologists all in the same room, so we can just do our little 20 minutes and let the other people do their stuff. And to the extent that you can do that, great. But finding people who are willing to do those things will make your life and your patients' lives better. Thank you. I'll take any questions.
There's situations where you get NITs where primary doctor gets a FibroScan and you have your elastography and they're discrepant.
So that is a very common problem. What do you do when your NITs are discrepant? Well, to me, the MRE is the gold standard. And also use your clinical judgment. I saw a patient this week who had a FibroScan that they said was 14. Patient had a platelet count of 250,000. They were relatively thin. They had mild hyperlipidemia. They had normal liver enzymes. Their FIB4 was 1.0. And I was like, that FibroScan is just wrong. And I sent the ELF, and then I had 3 out of 4. And if worse comes to worse, the FibroScan. Then you have some where it's the reverse. You think they have cirrhosis, but they have an NIT that doesn't. Every once in a while, you do need a liver biopsy. And the other thing to remember is that FibroScan does not work well. It overstates fibrosis when the ALT is well above 100. And so if I have someone who has an ALT of 250, I don't even do a FibroScan. It is not very helpful. And it also overstates your NASH FibroSure. Gilbert's also will screw up your NASH FibroSure because it has bilirubin in the model. So you have to know what the model is and what NIT and then go from there. But I would say if I do 1 liver biopsy a year for discrepant staging, that's probably the most. Wow. And so it should be rare. And then that's what you do. And the one that has the most error rate is FibroScan because it is very operator dependent. And they say that the machine doesn't let you do it, but I can give you, if I play around, I could get almost any score I want. If I just, get a little rib shadow and you can fool it, it will give you a measurement. And so that's the issue. And the problem is most people don't do their own. And so they have to live with it. But, you also see ones where the IQR is 50%. And that, if someone's sending you a report with an IQR of 50%, not only is that FibroScan not useful, never send that person another FibroScan again because they're not doing a good job. So the answer is use multiple, know which components go into it, clinical judgment, MRE whenever possible, and then if you get to the end of the road, then you occasionally need a liver biopsy. Yes.
There age where they'll start Rezdiffra, an age where you may or may not start Rezdiffra, and 2, regarding statins. A lot of these patients have underlying coronary disease and have had MIs or strokes, and now we're on high-dose statins. How do you manage that?
So the first thing, so the 2 questions is there an age at which I wouldn't start Rezdiffra? I think the answer is, of course, there is. The younger they are, I wouldn't start someone over age 75 who didn't have F3, maybe. People who have significant coronary disease are going to die of other causes. I think it's a risk-benefit decision, but I don't have a fixed endpoint. The second question is this whole statin abnormal liver function test issue. And the first thing is that the risk of statin-induced liver toxicity is 1 in 10 to the 6th. It is actually lower than most drugs. Think about the billions of I have never done a liver transplant for statin hepatotoxicity. So it just doesn't really happen that much. So what happens is if you only start statins when the liver tests are normal, you will convince yourself that you're seeing statin hepatotoxicity because NAFLD has fluctuating liver tests. And if every time they go up, you stop them, they're going to come down, either because they were just going to, which is most of the time. But if you continue them, they actually come down anyway. So high dose statins, I think that rosuvastatin probably and pravastatin probably have a better liver safety index than Simva or Atorva. And so if patients have high liver tests, fine. And then the second thing is know when to give up. And just I tell them to put the patient on Repatha and you're done. Or a Repatha-like drug. Repatha is the only one I know. I don't even know what the generic name is. So it's ever something a mab. But I don't know who makes it either. So I don't have a conflict of interest.
Yeah.
But the answer is they have to control their lipids. And that isn't your job. Your job is to say, 1, start them with abnormal liver tests. And the higher the liver tests they start with, the more they'll become encouraged because they come down. And then what I say is as long as the bilirubin stays normal and the alk phos doesn't double, as long as the liver tests don't double, just stop fretting.
Yeah, I mean, I think the package insert talks about like Lipitor, like it may increase the dose of lipid. You may want to adjust the dose of your statins when you start Rezdiffra.
So yes, you have to drop the dose of the statins, but they will remain equally effective because it inhibits the metabolism of statins because they are CYP2A, not CYP3A4, CYP2A28, someone and the other one.
So you cut it
in half. So you cut the dose in half, but you'll find that the effect on their lipids will not go up. 1, because Rezdiffra lowers lipids, and 2, because the effective dose of the statin goes up. So you can reduce the dose of the statins and not worry about it. And you'll check your lipids at 3 months. You'll find that most of my patients, even when I've had to cut the dose of the statins, their lipids are the same or lower.
Patient that on their FibroScan and the MRI, they have an F3-4. It really says F3-4. You have a patient with FibroScan and MRI, it says F3 to 4. They're already on Mounjaro. Would you start them on Rezdiffra? And will it get approved if you have to send in the medical records?
The answer to the first question is easy. If they have a normal platelet count, yes. I'll believe they certainly don't have portal hypertension, and I'm good. Will I get it approved? I don't know. I had one where I sent the report and it said F3/4, meaning 3 out of 4. And the insurance company said no. And I sent a letter saying that's 3 out of 4. It's stage 3. And they said, no, it's 3-2-4. I said, I don't even know what to say to you. And then after the peer-to-peer, we got it approved. The answer is that it's only contraindicated in cirrhosis, which is stage 4. 3.5 is not 4. And so my feeling is, as long as I feel comfortable that they're non-cirrhotic. So if you're saying I need to do an endoscopy to rule out varices, et cetera, then that patient probably is not the right patient. But if you feel comfortable not doing an endoscopy because the platelet count's normal and says this is not stage 4, which is the answer, it's not indicated in cirrhosis. 3 to 4 is not cirrhosis. So I'm good.
So with this new drug available to us, do you, when somebody comes in, you do the FibroScan or whatever non-invasive testing that you do, the magic number, the magic 8 ball is over 8. Do you start it? You start medication immediately? Do you say, we're going to do this is what you have, let's do a trial of lifestyle modifications? How do you approach an otherwise healthy-ish person, 40 or 50, with that condition?
Well, I think you have to have a discussion, and so, resmetirom is approved in conjunction with lifestyle, right? They're not, as I said, they're not either or. It's ideally both. And so someone who has early stage 2, and they don't want to take a medication, I'm okay with trying lifestyle modifications as a first step. Someone who has tried and failed, which is what most of our patients have, I said, why don't we reverse your fibrosis, give us a longer runway. Once they get to stage 3, you're going to be doing HCC screening potentially. You're going to be worrying more, and then still work on lifestyle modification. And what I tell my patients is, you have to decide, are you the kind of person who wants to be very proactive? Or do you want to minimize medications? And if you want to, my dad, who is a very brilliant physician, if he had stage 2, he would try lifestyle modifications for years before he would, because he hates medications for himself. For his patients, no problem. My mother and I, we hate complications. And so we would both probably take Rezdiffra. And we're at slightly different age groups. My mother would not want to have fibrosis. And so I think that you have to ask them. And the answer is, do you really think you can lose 10% of your body weight and keep it off? Because if the answer is no, I've gone up and down and this is what I've been since I was in college, then you might as well do resmetirom before they have stage 3 and then still work on everything else.
Someone entered a question into the chat. What would you do if you had a 2-time increase in the ALT after 4 weeks of Rezdiffra? Would that concern you at all?
No. That's actually, the mean is 1.5. So 2 would be well within what's expected. So as I said, try not to measure it. It makes you crazy. It really does. And it makes your nurses crazy, because then the patients make them crazy. And so, I don't deal with most of the craziness. My NPs do, but I stopped measuring it, and I think my NPs are much happier with me. But it is going to go up. And so if you're going to measure it at week 4 and 2 is going to bother you, then either don't start it on anybody or don't measure it.
So I have 2 questions. Number one is, how about the patients who have just type 2 diabetes, no obesity, no hyperlipidemia, but they have F3 fibrosis? So, I believe some Asian patients, what I was told, that due to some abnormalities, they are more susceptible to developing this fibrosis, NASH type of behavior. And I have few patients which actually gone to cirrhosis and liver cancers, which I could not understand why they had so. And second question I have is, how about a patient has history of hepatitis B, which is the carrier, or they are on therapy with no viral count, 0 viral count, yet they have F3 fibrosis. So what about those patients? Are they candidate for Rezdiffra or not?
So the answer is yes. They're both candidates for Rezdiffra. And the fewer metabolic risk factors they have, the more Rezdiffra is going to help you, right? The more resmetirom is going to help you, because you can't control the underlying metabolic factors, and they probably have PNPLA3 or some genetic predisposition. With the hepatitis B plus NAFLD, you have to decide whether you think the fibrosis was due to their hepatitis B, in which case then just suppressing hepatitis B would help, or if you think that it's due to MASLD. It may have independent antifibrotic effects, but that's not proven. So I think if you feel they have MASLD as a contributor to their fibrosis, yes, I would do it. And certainly somebody who has all the risk factors controlled or very few risk factors, resmetirom is going to be the only thing you can do to change their outcomes.